Looks great.
Awesome. Thank you, Dr. Harlan, for inviting me. DC is so thrilled to have you. Like you said, the second that you came in, you've just been a powerful force within the district. So thank you, and thank you for having me here. Good afternoon, everyone. Good morning to those who are on the West Coast. Thank you so much for joining my session. I think I'm the last one to take us home before our panel discussion. Today I'm going to be walking you through, like Dr. Harlan said, the diabetes prevention program. We'll go over its history, the delivery, and then how to partner with a community-based organization. My name is Kristy McCarron, and I'm the Association Director of Community Health for the YMCA of Metropolitan Washington. In this role, I oversee the implementation of all of our health promotion programs, including the diabetes prevention program, as well as culinary and nutrition education, a blood pressure program, and medical nutrition therapy. Additionally, I oversee our clinical integration to create bidirectional referrals into the YMCA programs with healthcare organizations. I know that many of you are familiar with the Y, probably our pools or our basketball courts or summer camp, but today we're focusing on a newer, more clinical side of the Y, which continues to grow across the country. So the goals of today's session, my hope is that by the end of the session, you'll be able to describe the burden of diabetes in the US and the diabetes prevention program's effectiveness in decreasing this burden, describe the history, program delivery, and inclusion criteria of the diabetes prevention program, understand the importance of clinical community integration and how to bring this to your practice, and identify the unique role of clinicians in partnering with community-based organizations who deliver the diabetes prevention program. In short, really my hope is that you walk away from today's session understanding the importance of clinical community integration and feeling empowered to create these partnerships with some real concrete ideas. What's really great about this conference is that it can leverage the diversity of folks who work in public health. And so we'll use this to discuss and think about how we can better enhance population health. Hopefully at the end, you'll have a better understanding of the perspective of a community-based organization. So you have a clear understanding of how to partner and what types of programs are offered. Though I'm talking about the YMCA here, we are certainly not the only organization that provides the diabetes prevention program. Some of your organizations might also provide it. And additionally, this presentation could be applied to any evidence-based health intervention once we get to the integration part. So we'll first go over the burden of diabetes today. We'll start with some of the data, and then I'll describe the history and effectiveness of the diabetes prevention program. I'll probably call it DPP from here on out. And then we'll go over the need for clinical community partnerships and then what this looks like in practice. I'm sorry, after DPP's history, we'll talk about what it looks like in practice, then the same for clinical community integration and what it looks like in practice. And then I believe questions can go in the chat so that we'll talk about that in our panel. All right, so let's get started. First, I think, like I mentioned, what I think is so unique about this conference is that we can bring together a lot of folks from all over. So I would just love to get a feel, and I'm gonna try a poll. I would love to see who's in the room. So if you can just look at this poll, you should see it on your screen, and identify which of these best describes your role. I'll give it a few more seconds. Awesome. Okay, I'm gonna close it. So let's share the results. So really the bulk of folks here, like we expected, are physicians, but we do see quite a variety, of course, of dietitians and food service professionals, nurses, community health workers. And this is really what's great here. I think hopefully throughout this presentation, we'll identify where each person in the public health world, where they can fit in this conversation. So I'm gonna close this. Great. All right, so let's talk about the burden of diabetes today. So there are 34.1 million American adults who have diabetes. That's about 13% of our population. And of that 34.1, about 26.8 million adults are diagnosed, and that's 10% of our adult population. So they're what we call above the iceberg. We know that they have diabetes, they're diagnosed, and hopefully they're managing their diabetes. But right below that is folks just beneath the surface, and those are folks who are undiagnosed. That's about 7.3 million adults who are not diagnosed with diabetes and therefore may not be managing their diabetes. That's about 3% of the population. You may be wondering how we know this number. So this number comes from NHANES data, which is a door-to-door survey, making it very accurate. So what happens is an individual is asked if they have diabetes, they say no, their blood sugar is taken on the spot, and it turns out that they do. So unfortunately, this number is pretty high. And when we look further into these numbers of who is diagnosed and who's undiagnosed, we see there's a lot of similarities. So first I wanna note that this is in the millions, it's not percentages. So this is our 26.8 million American adults who have diabetes. And among them, about 22 million, so most of them fall within this 45 and up range. We don't see a huge difference between men and women. And then when we go to our folks who are undiagnosed, the 7.3, we see the same pattern. So about 6 million of that 7 million are undiagnosed, are above the age of 45. And we see an almost even split between men and women. This chart shows the prevalence of diabetes by race and ethnicity, and it's important to recognize that a disparity certainly exists here. So we see that our most marginalized populations have the highest percentages of diabetes. First, the American Indian population with about 15% of their population having diabetes. Next, our Hispanic population, again, around that 12 to 14%, and then a Black non-Hispanic population. So it's important to understand, or think about what leads to these disparities and why they're significantly higher than the white population. I'm sure that we would likely find correlations between poverty and education and diabetes. But in addition to thinking about what leads to these disparities, we also want to consider, what is allowing these disparities to persist among these populations. And lastly, the financial burden of diabetes in the US. So 1 in every 7 healthcare dollars is spent treating diabetes and its complications, and it totals up to about $327 billion annually. Of that 327 billion, about 237 billion is in direct medical costs, and about 90 billion is in reduced productivity. The largest components of the medical expenditures include hospital and patient care and prescription meds, both at 30%, followed by anti-diabetic agents and diabetes supplies, and then lastly, physician office visits. Who are we missing? So if we go back to the iceberg, we know, again, this 34.1 million adults have diabetes, though some are undiagnosed. But in addition to that, we have another layer of folks just below those who are undiagnosed, and those are individuals who are pre-diabetic. 88 million American adults are pre-diabetic. That's about a third of our adult population. And this is where the work of the Diabetes Prevention Program comes in. But let's look at those numbers again. So this is that 88 million who are pre-diabetic. Unlike what we saw among those with diabetes, we don't see any significant differences between populations here. I want to remind folks again that we're looking at millions, so we see that there is a bit of an increase among the 45 to 64-year-old crowd, but it's not as significant as what we saw for those who are diagnosed. Women are a little bit higher, but again, not that significant. I think what we see here is that there is a significant portion of the population across a variety of ages, sexes, race, and ethnicity who are dealing with prediabetes, which means that there's a lot of room to intervene among a number of different populations. I want to highlight also what's happening with our youth. So we do see that there is an overall upward trend. And we also see the disparities that's similar to what we saw in the adult population. This is the Black youth, again, pretty significantly higher, followed by Hispanic. And here, this is our white population that stays pretty low and steady. So the Diabetes Prevention Program, let's talk about it. The Diabetes Prevention Program, or NDPP, National Diabetes Prevention Program, we call it YDPP, was created in 2012 to address the increasing burden of prediabetes and type 2 diabetes. It was truly a national effort to create partnerships between public and private organizations to offer an evidence-based but cost-effective intervention. One key feature is that it's a CDC recognized lifestyle change program. And initial research saw that it reduces the number of new cases of type 2 diabetes by 58% and by 71% for individuals over the age of 60. And then a brief history. So really a lot of the research and first randomized controlled trials for DPP started in the late 90s, early 2000s. And that's when they really started to evaluate the effectiveness of a lifestyle intervention program for those at risk of diabetes. In 2002 is when the first published findings showed this 58% reduction in type 2 diabetes. A few years later is when the Y was really identified as this place to get something like DPP to the masses. Those in the Y, we have this statistic that I didn't put on this slide because I don't know where it comes from, but we often say that 60% of American households live within 5% of a Y. So it can truly be a force for public health good. We're everywhere. And so that's why, something like DPP can spread to the masses if enough folks within the Y are trained in it. In 2010, Congress authorized the CDC to establish and lead DPP, which really created this national infrastructure. And then in 2012, the National YMCA created a Medicare project in the Center for Medicaid and Medicare Innovation, which eventually led to this Medicare coverage for DPP. And then in 2017, the Y really started working on more electronic referrals with local healthcare organizations, which we'll talk about in future slides. So I mentioned the YUSA Healthcare Innovation Project, and this really was to identify whether or not it would be feasible for something like DPP to be reimbursed by Medicare. Not only was it tracking if the program was effective, but if somewhere like the Y could really maintain something like DPP and a reimbursement and following a fee schedule. As you can imagine, that's out of our wheelhouse. But with the research that was done 4 years later, the HHS secretary made a decision to cover the diabetes prevention program via Medicare. So that was really a game changer for the Y and for most community-based organizations. And this was the first ever community-based program to be covered by Medicare. So let's talk about what DPP looks like in practice. But before we get in, I'm going to try another poll. So let me do this. Okay, so DPP, of course, requires that folks are pre-diabetic. So let's see if folks can identify what would qualify someone as pre-diabetic, therefore qualifying them for DPP. All right, I'm gonna close this. So we were correct. So folks that have an A1C between 5.7 and 6.4 are pre-diabetic. So if you selected an A1C of 6, then that is someone who would qualify for DPP. Awesome. All right. So DPP is led by a trained lifestyle coach. So at the Y, we get trained by YUSA staff, and in addition to being trained in the actual program, YUSA, we're also trained in things like motivational interviewing, weight bias, to make sure that folks coming to the Y really feel like they have a safe environment. DPP is a year-long program. It is an intense program. It includes 19 sessions in the first 6 months and then 6 sessions in the second 6 months. The 19 sessions in the beginning first start weekly, and then they go to bi-weekly, and then ultimately it goes to the once a month. Because it's a year-long program, we know that someone who's signing up for a year-long program is probably pretty far along their readiness scale. So that's also probably why we see so many good results. Folks are really dedicated, and I know anecdotally the folks that are participating in DPP within our association are participating in almost all of our health programs. So they're really motivated to change. The program goals are to reduce body weight by 5 to 7%, and then to increase physical activity to 150 minutes per week. Again, this is why doing DPP at a place like the Y is really great, because hopefully folks are, also working out at the Y as well. The inclusion criteria includes that an individual must be 18 years old, have a BMI of 25 or greater, and then has confirmed diabetes via either an A1C of 5.7 to 6.4, a fasting glucose of 100 to 125, or a diagnosis of gestational diabetes. The program consists, like I said, of intensive core sessions, 19 sessions furnished over 6 months. And these are in a group-based classroom-style setting that provides really practical training in long-term dietary changes, as well as increased physical activity and behavior changes for weight control. After an individual completes those core sessions, they then have less intensive follow-up meetings that happen once a month for the next 6 months. So this is really where the diabetes prevention program is able to, capture that maintenance phase that in public health we're often not able to do. So they're constantly, in touch with their individuals. There's ways to re-engage. Each week during the sessions, participants weigh in and they discuss their homework from the previous week. So this may include something like discussing tracking their food in a food log, or how reading a nutrition label worked. And it truly is a learning environment. So lifestyle coaches are given a topic each week, but much of the session is designed for participants to really learn from one another by discussing their successes and hurdles. This group-based model really creates strong cohorts, and which aids in the individual success. But there's always hurdles. So here's some of the hurdles that we've seen within our program. The first is recruitment. So despite a lot of folks being pre-diabetic, it's still hard to get people in this program. And I think that this may be dependent on where the YMCA is located. Since we know that there's a strong correlation between poverty and diabetes, the location of the YMCA in more affluent neighborhoods may prevent us from being able to reach those who need it the most. So this means we have to really rely on creative partnerships or unique recruitment ideas, such as working with churches or summer camp registration. The second hurdle that we face is payment. So the recommended cost for DPP is $429 per participant. And though many private health insurances cover this, not all do. So, or they require reimbursement. So YMCAs rely heavily on grants or fundraising to cover all or a portion of the cost for participants. Billing. So I mentioned that we are able to get Medicare reimbursement and in some states also Medicaid reimbursement. Though this is a great option, like I said, this is out of the wheelhouse for something that the Y traditionally does. And it's a significant amount of work on the Y's end, which may make it prohibitive. I can speak for us here in DC. We're just in the process of getting Medicaid reimbursement in Maryland. Because it's a little bit easier, and then we'll use that to get our Medicare reimbursement. But also this reimbursement is based on a combination of attendance and weight loss. So you can imagine that this type of tracking and HIPAA compliance is just new and therefore a little bit difficult for a YMCA. But generally, this is getting easier, and we expect that Ys will continue to move in this direction. There is also a lot of support from local health departments to encourage this. Social determinants, so we often hear that things like transportation, childcare, access to a computer in a virtual setting, or access to food are barriers for individuals participating in DPP. Clinical partnerships, this is our North Star of our health programs, but again, it's still like a new language for a place like the YMCA, so it's a pretty big learning curve for us. And then of course the pandemic, right? So we've put all of our health programs online, and we've seen that they're mostly successful. We have pretty high retention rates, but it does limit folks who do not have internet or a computer to participate. And here's the effectiveness of DPP. And this is from YUSA's database from 2019. So you can imagine that a lot of DPPs were put on hold during COVID. So there was about 65,000 participants who attended at least one session. And the average weight loss at the end of weekly sessions was 4.6. And at the end of the year, the average weight loss was about 5.5%. With the average weekly physical activity was 162 minutes. So these are those two goals that we're shooting for. The chart to the right shows feedback that we got from participants at week 8 and week 16. And if we look at week 8 in the orange, we see that 91% reduced their portion sizes, 85% increased their physical activity, and 83% improved their overall health. And then when we get to week 16, we see that 93% have reduced their portion sizes, 88% increased their physical activity, and 91% have improved their overall health. So now let's shift into this clinical community partnerships and integration, and then we'll bring it back to DPP. So many community-based organizations, such as the Y, are historically really good at addressing factors that impact an individual's health outcomes outside of healthcare. So this may include something like socioeconomic factors, so education or job status, certainly social support, a physical environment. We may be able to provide a safe space for an individual to be physically active. And then programs like DPP also allow us to address health behaviors, or we can talk about diet and exercise with dietitians on staff, or even our personal trainers. Additionally, places like the Y are typically a trusted voice in the community. Like our bread and butter is relationships. So we're able to work with a variety of populations. And this allows us to hit populations who are oftentimes not reached or not represented. And we know this to be particularly important when we're addressing health disparities. And additionally, we know these types of partnerships are important because the changing landscape of healthcare is promoting this shift towards population health, value-based care, and this focus on factors that influence health outside of the clinic. So healthcare delivery and payment models shift away from that payment based on volume to that payment based on population health outcomes. And therefore, we're really encouraged to create these comprehensive population-based strategies that address both individual behaviors as well as social determinants of health. So this is really where a place like the Y can come in and operationalize these meaningful partnerships between clinicians and community-based organizations. I will say, though, that a place like the Y and community-based organizations have a tendency to provide and give and give and give. But oftentimes this limits the long-term sustainability of a program like DPP. If we are not, generating revenue or sustaining the program, then it just won't last. So to achieve this impact, we've really been encouraged from our national office to develop really formal partnerships, knowing that we'll accomplish a lot more if there are clear goals, clear action steps within defined timelines. So here's what they look like. These clinical community partnerships look like in practice. So the goal is to move from a partnership to integration. Partnerships, they almost always start as a grant with a really great idea, and then they move through multiple sources of funding with the long-term goal of an insurance reimbursement and a joint service delivery model. They really most often require multiple sources of funding. And of course, demonstrating the value of the partnership is critical. Therefore, data collection and data sharing agreements are necessary. Additionally, mission alignment and cultivating trust are also critical for ensuring that the partnership doesn't just fall on one party. So with a more comprehensive approach to engage with healthcare, we've kind of reframed the goalposts, and no longer is developing a referral system just this singular goal or the end game. But rather it's now a one step in a larger process towards developing a more comprehensive partnership. So typically this is what we see. The Y says we have a shared space and we have something like DPP. And then we develop this formal referral pathway. Keep in mind that though this line is short, this development of a referral pathway can take a really long time. We're currently in the process of developing one with an insurance company here in DC for our blood pressure program, and the MOU process alone has been going on since October. So this takes some time. But once it does happen, the Y can demonstrate improvement on clinical outcomes and hopefully a reduction in the overall healthcare expenditures. And then from here, both organizations establish a sustainability plan when the Y demonstrates its value add to the healthcare stakeholder and receives fair market reimbursement for their program. Truly, reimbursement is the primary driver of program sustainability. And lastly, this ongoing partnership evaluation. Bidirectional information and outcome sharing really drives the refinement of this referral pathway. So in this type of relationship, the Y or the community-based organization provides the clinical quality that it provides to the clinical quality and cost measures to providers are therefore, we're held accountable to this. So we first align the vision with key internal stakeholders bought in. We formalize the partnership with a written agreement, and this includes a communication plan, understanding what outcomes folks want and how frequently they want them. And then also establishing some sort of set meeting structure. So we're always talking about how many referrals and what their outcomes are. And then we build and pilot those workflows. And then hopefully we scale them up once we know that those workflows once we know that they work and all of the details have been ironed out. So I know that healthcare providers and clinicians only have a few minutes of time to really spend with patients and may not be able to offer much of the day-to-day support. And really, I think that's where a place like the Y comes in, because that's what we do best. We provide a comfortable, convenient place for individuals to visit consistently and experience empathy and receive guidance from a trained staff so that they can reclaim their health. But these are some of the ways that we've seen clinicians to be helpful. The first is to provide direct program referrals of eligible patients to the Y. Additionally, you can help to champion the program among other healthcare provider groups and stakeholders in the community. Engage leadership in conversations about developing systematic approaches to program referrals. Provide or help secure space for program sessions. Post or distribute the marketing materials to raise program awareness. And add the program to your community-based resource directory. What I've seen to be the most helpful is these two. So providing, of course, the direct program referrals. And then once that happens and we've demonstrated outcomes, sharing this with leadership. Often we rely on one champion at a healthcare organization, but we know that one champion will not change the culture. More often than not, we need to get IT involved. So starting here and then sharing those outcomes is really where we're more likely to see these sustainable partnerships. So we also know that referrals and communications are not designed to go one way, that you'll likely want to hear from us how your patient is doing. And so this is what an ideal bidirectional communication pathway would look like. First, the patient visits the healthcare provider and is screened for a chronic disease, in this case diabetes, and provides consent to be referred to the YMCA. The healthcare provider refers to the Y via our agreed upon referral format and includes the key information. The Y then contacts the patient, confirms their qualification and interest, and enrolls them into the program. And then the Y provides updates to the healthcare provider on the patient's progress once the program starts. This tends to vary. We actually most often see that providers just want to hear at the end of the program how their patient did, but given that DPP is so long, we may share updates more frequently. And then lastly, the healthcare provider monitors the patient's progress and reinforces behavior change with the patient at the next visit. This, of course, includes an ongoing process improvement and relationship building, communication, aggregate data. Again, really crystallizing in the beginning what information would both parties like on what basis. Is it monthly updates? Is it quarterly updates? Just getting that started in the beginning is really helpful. And this is what more often than not is exchanged in the referral. So typically we're asking for the patient name, and of course the contact information, their demographics, the practice that they're being referred from, and then any relevant clinical information and inclusion criteria. And then of course, if they prefer to be at one specific YMCA. And then what we provide back, again, is that patient identifier, the practice and provider identifier, which Y they came to, and their program outcomes. For DPP, typically what we're sharing is their attendance at each session, their weight loss, as well as their physical activity. And here's how referrals might work. So I'm sure that you are already referring to other community-based organizations, so this might be familiar for you, but of course, typically we used to see a lot of paper referrals, but now we're, for the most part, working with electronic referrals. But they both work in the same way. Either the referral is, either the patient signs a consent form and then the provider gives that directly to the Y, or the referral is given to the patient and then they're responsible for reaching out to the Y. We typically don't recommend the latter because we don't see as many people reach out to us. We also, for HIPAA reasons, really prefer that things, of course, are done electronically. And here's some of the electronic pathways that Ys use: either a chart export, direct messaging, secure fax, or secure email. Many Ys are now using a service called Weld. It's an EHR that was created for the Y that allows us to have direct communication with various EHRs, as well as track our touch points and an individual's outcomes. So those also use these secure fax and secure email so that we have an easy way to communicate with the providers. And then, of course, there's the timing of when the referral happens. So in the long term, we really want to see this point of care, the referral happen at point of care. I know that there's some Ys, I think it's actually just one, but their local hospital system has it set up within their EHR that when an individual has an A1C that, you know, is pre-diabetic, it flags them and then immediately refers them to the Y. So that's like a best case scenario, that the Y is getting a referral right away and it's not much work on the clinician. But we also see a lot of these short-term retrospective EHR queries, and I actually think that they're really helpful, especially if you're working with an insurance company, because they're able to filter their members and then identify who has the inclusion criteria. But also it allows us to get a larger list, and then we can fill up a class and then host a class right away. And this is, you know, what a referral form might look like. We are just searching for some of this basic information. I'm sure you've seen something like this before, but as it relates to DPP, we just need to know that an individual is 18, has a BMI of 25 or greater, and then an inclusion criteria of pre-diabetic. So I've talked a lot about, you know, what this looks like from the Y's end, and I'm really hopeful that there's some tips in here that help you understand, you know, who are the people that we could be working with in your community. It may not be a Y, but it may be another community-based organization. So here are some things that I would just love for you all to think about. I'm going to pose some questions and just give you about 10 seconds, 10 to 15 seconds, just think about them. So the first one is, how are you currently generating referrals to other community-based organization resources for your patients, and how are you tracking these referrals? So how are you currently generating referrals, and how are you tracking these referrals? What opportunities do you have to integrate referrals within your existing clinical workflows? Who else do you need on your team to make this work? I promise you, you'll need IT. And lastly, what metrics should be collected to determine all protocols are successful? Thank you so much for tuning in. We really know that there's so much work to be done and to reach those 88 million Americans who are pre-diabetic. And I really do believe that all of us bring a unique skill set to reduce the risk of diabetes. Thank you so much. I will see everyone in the panel, but here's my contact information if you have any other questions. Thank you.